Hello, followers of Neuro Takeaway. Welcome back to the channel. Today we are going to talk about a very important issue, such as the metabolic and toxic disorders of adults, always from the imaging perspective. I would like to thank Synthon-Bagó pharmaceutical company for the support, and I remind you the importance of your subscription to the channel if you like it. So without further ado, let's go to the talk. Hello, this talk will be about toxic and metabolic disorders in adults. The schedule is the following. To start, we'll be speaking about adult leukodystrophies, then about acquired metabolic disorders, and finally about old and new poisons and drugs. What about leukodystrophies? Well, as you know, these diseases are usually found in children, but we are seeing them more and more in adults. And the reason of this is probably the frequent use of MR in the population in general. And on the other hand, we have to understand that these metabolic disorders may have some mutations that leave some partial enzymatic activity. So if the enzymatic activity is too low, we will have the presentation in children in infancy. But if the residual enzymatic activity is not that bad, we can find them in adults. And what's more important, the presentation and the phenotypic pattern on MR may be different in children and adults. In general, these processes affect white matter, but sometimes they compromise gray matter too. They have different patterns of inheritance. Maybe some of them are autosomal dominant, others are autosomal recessive, and there are a few with X-linked patterns. The course is progressive, and the symptoms are usually unspecific, but we have to think of them in a middle-aged man or woman with a cognitive disorder, maybe with a psychiatric presentation, and sometimes they are associated with peripheral neuropathy and autonomic disorders. Around 50% of them remained without diagnosis. There are 4 pillars for diagnosing these processes. We have the clinical symptoms that, as I said, are very unspecific. The lab, the genetic testing, and the imaging. On imaging, MR is the more important. Sometimes we use PET, and sometimes CT may be useful for the detection of calcifications. But what's the problem in adults? Here we have a problem that we don't have in children, which is the presence of microvascular disease. As you know, the leukorrhiosis, which is the compromise of white matter secondary to microvessel pathology related to several vascular factors as smoking, hypertension, diabetes. That picture can be on imaging very similar to a leukodystrophy with a pretty symmetric or relatively symmetric pattern. Here we have on the left side a patient with severe leukorrhiosis, a grade 3 of Fasek's scale. And in the middle, we have another case, pretty similar to the first one, but this is a metachromatic leukodystrophy. What are the differences? Well, you can argue that there is a very symmetric pattern. There is compromise of the corpus callosum, and sometimes in this process, in this leukodystrophy, which is the second most frequent leukodystrophy, in general. Sometimes we can see the striated pattern, but this is not pathognomonic of this process. And on the right side, we have another very important differential to microvascular disease, which is CADASIL. CADASIL is also a leukodystrophy. It is associated with small infarcts, microbleeds. It's asymmetric, and it's one of the more important differentials of microvessel disease on imaging. Here, the history, the familiar history, very important because this process is autosomal dominant. Here we have two cases. Case one is a 9-year-old boy, and the other one is a 48-year-old male. In both cases, you can see the compromise of the white matter, supratentorial periventricular white matter with a symmetrical pattern, with compromise of the corpus callosum, the splenium, and in both cases there is an involvement of the corticospinal tracts. And in spite of being very similar, these two cases are completely different in etiology. The left side is adrenoleukodystrophy, which is the most important and most frequent leukodystrophy in children. And the other case is Krabbe disease. What I want to highlight here is that sometimes the phenotype, the MRI phenotype, is very confusing. For instance, Krabbe in children is different from ALD, but in adults, the compromise of the corticospinal tracts is the rule. Well, let's talk about some cases. We can't cover all of them because there are more than 40 leukodystrophies in adults, but let's see this one. This is a 38-year-old man with history of depression and mild cognitive deterioration who had been followed by a psychiatrist, but then he added some clumsiness and gait disturbances for which he complained to a neurologist. He did an MR, and we can see here the compromise of the white matter with an asymmetric pattern, with involvement of the crus cerebri, the internal capsule on one side, subcortical white matter on the right side, and like an MS pattern, but with confluent plaques, and some of them have a restriction on diffusion. And what is more important, this restriction was permanent. Well, this is a typical case of hereditary diffuse leukoencephalopathy with spheroids. This process is very rare. It has an autosomal dominant pattern of inheritance, and it is secondary to a mutation of the colony stimulating factor 1 receptor. There are two receptors, the colony stimulating factor 1 and 2, and when there is a lesion or the deterioration of the one receptor, the other one predominates, and this leads to an increase in the function of microglia. So microglia generates this demyelination, and this is a very typical example of a macrogliopathy. Sometimes this process is associated with some pigments in the glia, and this is like a variant of this process, the pigmented variant. Another case, this is a 46-year-old male with history of several years of orthostatic hypotension and urinary disorders, who recently added the intentional tremor and spastic paraparesis. Here we have the MR of the brain and spine. You can see the symmetrical compromise of the middle cerebellar peduncles, some compromise of the corticospinal tracts, of the pons, and a very huge alteration of the supratentorial white matter with atrophy of the brain. and very, very severe atrophy of the spinal cord. Well, this was a case of adult onset autosomal dominant leukodystrophy. This is another autosomal dominant process associated with a duplication of the gene that produces lamin B1. Lamina B1 is a very important protein of the inner membrane of the nuclei of the neurons. It is associated with the replication of the cell and with the pores that are so important in the nuclei function. It is a filament protein. And when the function of the protein is gained, we can have this picture. And one of the most relevant, more important clinical finding is the autonomic dysfunction. Another case, this is a 62-year-old woman with history of motor sensitive neuropathy, neurogenic bladder, imbalance, alterations, and he evolved in a MS-like pattern with remission and remitting processes. And you can see here the lesion, the hyperintense signals in the brainstem, especially in the medulla, the compromise of the inferior and superior cerebral peduncles, the alteration of the corticospinal tracts, and the supratentorial periventricular white matter. You can also see the atrophy of the spinal cord and this funny shaped V inverted V pattern that indicates the compromise of the posterior columns of the spinal cord. And this is another rare process. This is not dominant, this is recessive, and it's an adult polyglucosan body disease. This is due to an alteration, a mutation in the GBE1 gene. This gene produces an enzyme, a branching enzyme for glycogen, and if glycogen is not, it doesn't have branches, it precipitates, it aggregates, and these aggregations are toxic to the cells. So we have this, finally we have this entity. And this is the last case of an adult leukodystrophy. This is a 34-year-old woman with spastic paraparesis. And you can see here the atrophy of the spinal cord and the lesions of the corticospinal tracts, especially in the brainstem, as well as the compromise of the deep cerebral white matter. Well, this is a typical case of adrenomyeloneuropathy, which is a frequent clinical presentation of adrenoleukodystrophy in adults, especially in women. It has a dying back pattern of the white matter compromise of the spinal cord. And we have to think of this process because it is very, very tricky. Sometimes it is confused with other processes. And the most important compromises in the spinal cord. Well, some useful tips. This is from our colleagues of Brazil, led by Professor Lucato. You can see here that, for example, if you have CSF signals in the leukodystrophy, we have to think about vanishing white matter, or CARASIL with lacunes infarcts. Leukoencephalopathy with axonal spheroids can be associated with CIS2, as well as leukoencephalopathy with calcification and cyst, which is a specific pattern of leukoencephalopathy. When you can find hypointense signals on susceptibility weighted images, for example, in CADASIL, which are microbleeds, or in leukoencephalopathy with cysts and calcifications, or sometimes the spheroids can be associated with calcifications too. Regarding the enhancement, some of them as X-linked adrenoleukodystrophy, Alexander disease, which has an adult variant, leukoencephalopathy with calcification and cyst can have enhancement. When it comes to a spectroscopy, some of them may have a peak of lipids as Jogren-Larson or cerebral tendinous xanthomatosis, and some of them may have a lactate peak, for example, leukoencephalopathy with brainstem and spinal cord involvement. Finally, the spinal cord involvement may be found in this last process, as well as in adult onset autosomal dominant leukodystrophy and leukodystrophy with brainstem and Alexander disease. Well, let's change gears. Let's talk about some metabolic processes. This is a patient with a very abnormal MR. You can see here the compromise of both putamen, very symmetrical. They have a hyperintense signal, but there are two linear, more hyperintense signals at the level of the external border, the external capsule and the internal capsule. This is what is known as the fork sign, and it is associated with some acidosis anomalies, but in this case, it was associated with uremia. Uremia, especially when it is secondary to diabetic nephropathy, can produce this pattern. And it is important because it is frequently reversible. Another case, another metabolic disorder, you can see a very subtle alteration on T2 and flare, but there is restriction in a symmetrical pattern at the level of the internal capsules, the lobular white matter, and the corpus callosum. The alteration goes up to the subcortical pericentral white matter, and this is typical of hypoglycemia. Hypoglycemia, which can be secondary to the consumption of high doses of hypoglycemiant drugs, can be associated with this clinical picture and with this MR pattern. And it is very different from the pattern that we see in neonates with hypoglycemia, where we see compromise of the posterior parts of the brain. Another case, this is like a very typical compromise of the thalami, the anterior parts of the cingulates, and the insula. Here we can see the hyperintensity on flare and the restriction on diffusion. This pattern is typical of hyperammonemia. Hyperammonemia is obviously secondary to hepatic failure, or sometimes secondary to Porto-Cava communication. So this is another reversible pattern. Here you can see a huge abnormality of the supratentorial deep gray matter with restrictions in the posterior part of the putamen, the compromise of the claustra, and the pons, with relatively sparing of the corticospinal tracts. Well, this is a very extreme case of osmotic demyelination. This patient had hyponatremia, which was corrected suddenly, very quickly, and as you know, this leads to demyelination, especially in the bones, but sometimes in extrapontine areas, as in this case. To finish up with metabolic disorders, this is another picture that we are seeing more and more nowadays. This is a young woman which came with alteration of her gait. You can see the subtle hyperintensity at the level of the corticospinal tracts, especially in the central valley, subcortical pericentral white matter. And there is restriction at these levels, and you can see a very subtle hyperintensity in the posterior parts of the spinal cord with the compromise of the posterior columns. Well, this patient turned out to be vegan, and she wasn't receiving supplementation with cobalamin. So this is a typical case of cobalamin deficiency. As you know, cobalamin has several roles in our body, but when we don't have enough cobalamin, there is an increase of methylmalonic acid, which is toxic for the myelin. Another case, now we are going to talk about some toxics. These are two cases. On the left side, we have a pretty symmetrical lesions at the level of the putamen with central areas of hemorrhage. On the other side, we have compromise of the putamen as well, but there are hyperintensities and restriction at the subcortical white matter in the frontal and parietal lobes. These are examples of methanol toxicity. Methanol is like a very toxic product because it is transformed in our body in formic acid, which is highly toxic for mitochondria. The key is the compromise of the putamen, and sometimes there are, as you know, compromise of the optic nerve as well. Another case, secondary to toxics. Here we have a young man with drowsiness and this funny pattern of white matter lesions that we took them as ADEM pattern. You have several foci of white matter alterations, many of them with restriction, some of them with enhancement, but the evolution was very poor. The lesions tended to confluence, and there was more mass effect, and finally the patient died. And the history was that he had consumed cocaine in high doses, and cocaine may produce several things in our brains, for example, strokes, hemorrhages, but sometimes it is associated with leukoencephalopathy, and now it is considered that this leukoencephalopathy may be produced by an adulterant of cocaine, which is levamisole. Levamisole is an antihistaminic drug that it is found in up to 70% of cocaine, especially in the States. We don't know in Argentina how often this product is found, but probably it's as high as the US. Well, what about some new drugs? On the left side, we have an MS-like pattern of white matter compromise, lesions at the periventricular white matter on both sides. And this was found in a patient with rheumatoid arthritis that was receiving infliximab. Infliximab is a very good drug for these processes, as well as for others inflammatory diseases. It is a TNF-alpha inhibitor. And I thought that TNF-alpha was a very inflammatory substance, but there is another function, or some function of this TNF-alpha, which is anti-inflammatory. And it is considered that the inhibition of this anti-inflammatory process, function of this substance, that it is the reason why these infliximab and others inhibitors can produce demyelination of the brain. On the other side, we have a patient with melanoma who was receiving pembrolizumab. Pembrolizumab is a checkpoint inhibitor, and it can be associated with compromise of both the white and gray matter, as you can see in this patient. And the reason of these lesions is not understood very well, but these checkpoint inhibitors, actually, they are inhibitors of inhibition of the tumor cells that produce certain substances that inhibits the function of T cells. So when a patient receives this pembrolizumab or other checkpoint inhibitors, the patient this can trigger pro-inflammatory process, especially in susceptible people, that can lead to demyelinating disease. More about drugs. This was a colleague of mine. She had breast cancer, and she was receiving a drug, and she started with some clumsiness and gait disorders. And you can see there is a very funny and very symmetrical pattern of involvement of the white matter, both at the lobular frontoparietal white matter and the corpus callosum, with very intense restriction. She was receiving capecitabine, which is a very useful drug for cancer. This is associated with can be associated with white matter lesions, and they were reversible, and she did well with the withdrawal of the drug. Here we have another completely different pattern with involvement of the deep white matter of the cerebellum. Both the peridentate and the ileum white matter are compromised on both sides, and there is also compromised of the inferior olive nuclei. This was due to the consumption of metronidazole. Rugilo, which is a very common antibiotic against anaerobic bacteria, can produce this encephalopathy. And to finish up with drugs, you have here the compromise of both thalami, secondary to a very common drug that we use very frequently in our countries in Latin America, which is isoniazid. Isoniazid is it's the most important drug against tuberculosis. And it can be associated, rarely, but you have to know this, with thalami compromised with restriction, which is reversible. The last case actually is this was a 17-year-old male with acute lymphoblastic leukemia. He was receiving a drug that is associated with this stroke-like presentation. You can see here there are not much on T2 and flare, but on diffusion you have a unilateral compromise of the central semiovale. This drug is methotrexate, as you know. And this presentation is very important because this is a reversible process. On the other hand, methotrexate is the most important drug against this type of leukemia, so it is a tough decision to withdraw this drug. Well, another case that I'd like to highlight, this is very new. This was recognized at the beginning in dermatology, but now we know that we can see this recall process as myelitis. These are patients that receive some drugs as pembrolizumab or paclitaxel against cancer, and they develop a myelitis at the level of a previous irradiated area. In this case, the patient had been irradiated at the level of the dorsal spine. You can see the bone marrow changes. And after receiving these drugs, she developed many years later myelopathy. So this is what is called as recall myelopathy. Well, to finish up, we can remember that we have a lot of differentials to these processes. Here we have a patient with compromise of the deep gray matter and the cortical gray matter, very asymmetrical, and this is an important point, with restriction. And well, this was a case of prion disease, Creutzfeldt-Jakob disease. Another case with symmetric bilateral compromise of the putamen. This is a CT. You can see the hyperintensities. This was not a leukodystrophy. This was a stroke. You can see on the CTA the lesions at both middle cerebral arteries, especially on the left. Another case here with abnormalities at the level of the deep gray matter. It is asymmetric, and there is a huge compromise of the pons and the middle cerebellar peduncles. But the most important thing is these funny, small and scattered lesions around the process. And this is the key. This is PML, progressive multifocal leukoencephalopathy secondary to JC virus, can produce this leukodystrophy-like pattern. And the key is also the history of immunosuppression. Finally, a case with a lesion, asymmetric lesion of the white matter, associated with hydrocephalus, communicating hydrocephalus. There was compromise of the deep cerebellar white matter, and this case turned out to be a diffuse glioma. So these gliomas with a leumatosis cerebri pattern can be confused with leukoencephalopathy. Well, the lesson here, I think, is that we have to work together. It's impossible for a neuroradiologist to understand and to make a good diagnosis without very good communication with our colleagues, the neurologists, the toxicologists, the clinicians. So let's talk and share our knowledge. So here, thank you for your attention, and please subscribe to the channel. Bye-bye.